SSF. It's fantastic to connect with our colleagues and friends at the University of Maryland. And I see the good Dr. Steve Ludwig ready with his face mask hanging low. He's a low rider, and he's going to introduce us to his group, and he has a great topic revolving around the cervical spine and complications thereof. So thank you all for tuning in, and we're looking forward to a engaging 1 hour of education. Good morning.
Good morning. Good morning, Jens, and thank you so much. And I am a low rider, but I feel fairly confident that I'm not going to infect anybody on this transmission with COVID. So thanks for sharing with us. And I want to thank you guys for the opportunity to be part of the Seattle Foundation Journal Club discussion. We decided as a group to discuss some topics that will help improve the value and the quality care that we're providing and avoiding complications. I think that's important to all of us as clinicians and surgeons, obviously. So we thought that we would discuss some of the pearls and bring some salient articles about avoiding complications in cervical spine surgery to improve the safety. So without further ado, I want to introduce some of my partners, Dr. Dan Cavanaugh, Dr. Eugene Ko, Dr. Dan Gelb, who'll be part of this, as well as our three fellows, Dr. Nina Lara, Dr. Peter Cohn, and Dr. Soheeb Hashmi, and Dr. Jacob Bruckner, who's our research fellow as well. And what we thought how we would start today's discussion is with a case just to think about regarding cervical complications that Dr. Cavanaugh had to help out with. So Dan, without further ado, do you want to begin the discussion real quick?
Yeah, my name is Dan Cavanaugh. I'm one of the newer faculty members at Maryland. Do I have screen control, or how does this work? Do I have control over this?
Yep, you have control over the screen.
Perfect, thanks. So I just wanted to present a case that I was involved in a couple years ago, just kind of set the stage for kind of what could go wrong with a relatively simple, straightforward operation. How do I advance this?
Go to the bottom left corner. There should be an arrow appearing.
I'm not getting any kind of arrow.
Ashley, can you?
You can use your keyboard.
Yeah, okay. I'm hitting my keyboard, but it's not moving forward, so. Yeah, anyways, I could just tell you to advance the screen if it's okay.
Okay.
So this was a 57-year-old lady who had a previous history of an ACDF. She had an outside hospital ACDF revision procedure performed about a week prior, and she was transferred into my facility for fevers, crepitus in her neck, considerable dysphagia, voice issues, and she had some biceps weakness as well. Next slide, please. So this was her initial presentation. I think what you guys can see is there's a lot of essentially free air in her neck. You know, in the setting of a previous ACDF. Next slide, please. And this is always concerning when you see a CT that looks like this. Obviously, there's a problem here, right? There's essentially free air in the skin, subcutaneous tissue. So I took this lady urgently to the operating room in conjunction with my ENT colleagues and my thoracic surgery colleagues. Next slide, please. And what we found is she had an 8-centimeter anterior and posterior laceration of her esophagus. This was deemed to be irreparable by the ENT and thoracic surgeons. She had a laceration of a recurrent laryngeal nerve. I took out her plate, and because there was essentially an irreparable defect, ENT and thoracic elected to perform definitive closure with a wound vac and no esophageal reconstruction. These are her post-op images. We packed her and then eventually placed a wound vac. Next slide, please. So she got a PEG tube. She was essentially NPO for 4 months. We placed her on empiric antibiotics. In the scheme of things with her biceps weakness, I thought this was the least of her concern at this point. So we just observed this. Next slide, please. So as I followed her, what you could see here on the CT scan, she developed considerable increased neck pain and elevated inflammatory markers about 4 or 5 months after her initial surgery. And she has some lytic lesions at the levels of her ACDF and then several levels below. And this was, consistent with a late onset infection. Next slide, please. This is an MRI indicative of, osteomyelitis, which is chronic in nature, and not surprising given the fact that her neck was essentially left open for several months and closed with a wound vac. I had a pretty significant apprehension about going back in the front of her neck, and as did ENT and thoracics. They really thought it'd be contraindicated to go back in and perform an anterior debridement. So what we elected to do instead was just rigidly stabilize her from the back and broaden out our antibiotic coverage. Next slide, please. So this is what we did. I did a long segment posterior instrumentation, no anterior debridement. Next slide, please. So she started to consolidate her fusion, and then next slide, please. And by about 3 months, she actually healed her infection. Next slide. So she had a host of complications, including a complex esophageal laceration or perforation, postoperative infection, osteomyelitis, recurrent laryngeal nerve injury, and a C6 nerve palsy. So obviously this is a terrible complication and just kind of set the stage for, all the things that could go wrong in the cervical spine. So I'll let, I think Pete's up, right?
I think this is Jacob's article. And I think this case represents each individual complication is just a horrible disaster, but to have every single complication that we're about to discuss in one clinical case is just an absolute disaster. So thanks, Dan, for bringing that case in. Jacob, can you talk about this article we picked looking at complications and readmissions for cervical spine surgery?
Yeah, so this was published in 2017 in World Neurosurgery by David Bernstein. And just a little background, surgical spine surgery rates have been steadily increasing along with the rapidly aging United States population. And that combined with the increasing trend of alternative payment necessitates, an increased understanding on our part of the risks and complications for readmissions as we work these patients up. So this was a retrospective review of the NISQIP database of patients over the age of 65 who underwent cervical spine surgery from 2005 to 2013. During analysis, these patients were subdivided by age into groups from the age 65 to 69, 70 to 74, and over the age of 75. And then data was classified as a major complication, a minor complication, readmission, or mortality. And major complications included things such as sepsis, PE, deep surgical site infection, myocardial infarction, or peripheral nerve injury. The minor complications included things like blood transfusion, UTI, DVT, superficial surgical site infection, pneumonia, and wound dehiscence. And then a logistic regression model is used to evaluate risk factors. So as we get into the data, we can see that patients over the age of 75 accounted for almost 28% of the population. And in total, 9.8% of patients had at least one adverse event, with 3.98% having a major complication and just under 1.81%, 0.84% had a mortality. And as you can see from this table, the authors were able to identify that patients over the age of 75 years were associated with higher risk of complications. As we move on to the multivariate analyses performed by the authors, they were able to determine the risk factors leading to complications. So they performed multiple multivariate analyses, specifically for any complication or mortality on the left in table 3, any complication in the middle on table 3, and then for any complication in the over 75 age group, which you can see on the right in table 3. And then across all these groups, there were a few factors that were noted in all of them, specifically an operating time over 180 minutes led to increased complication rates, and the functional status of the patient led to increased complication rates. Other important factors that were noted were an ASA of 3 or greater, as well as a nutrition, endocrine, or immunology comorbidity was noted as a risk factor in the over 75 age group and any complication or mortality. So in addition, you can see here surgeons who had a greater than average number of work RVUs had decreased risk of complications. You can see the odds ratio is below 1. And then if we move on to table 4 down below, we can see a multivariate analysis of predicting risk factors for unplanned readmission. And the two primary ones were having at least one postoperative complication and an unknown functional status, primarily contributing to the risk of readmission. So if we move on to table 5, the authors performed another multivariate analysis comparing the risk factors based on surgical approach. So you can see on the left, risk factors noted in patients who received a fusion and those who received a laminectomy or laminotomy. So on the right, we can see for those receiving a laminectomy or laminotomy, age over 75, ASA of 3 or higher and a longer operating time led to increased risk in complications. Of note, there was no increased risk of complications total. So, in the patients over age of 65, there were no increased complications between the two fusion or laminectomy. So in conclusion, the kind of take-home points in this article that that they wanted to offer was, patients over the age of 75 have a higher risk of death or complications. And there are risk factors that we may be able to optimize, that can improve some of these patient outcomes when we're working them up in clinic. That includes like age, their functional status, how dependent they are on assistance, and their ASA. And although these risk factors can be challenging to avoid, it's important that, when we are working them up prior to surgery, we take into account some of these potentially avoidable or modifiable risk factors.
Yeah, thank you, Jacob. I think, we decided to look at this article because of the rise in baby boomers and population and, with age, degenerative conditions prevail. And there's no question that we're getting inundated with older and older folks that are not tolerating myelopathy, radiculopathy, or myeloradiculopathy, or other age-related degenerative conditions, or even tumors and infections and even trauma. So I think understanding how to mitigate the risk of an older person and understanding, their frailty sort of index as opposed to their chronologic age, I think is important as well. The ASA is used as a surrogate for frailty, I think, in this work. I think experienced surgeons are less likely to have complications, right, based on the RVU metric that you sort of described. I guess the question is, for Dan and Eugene, any thoughts on, how we take care of older patients, how we get them through a safe operation? When do we say no? Any thoughts on that, Dan or Eugene, or any of the other experienced docs on before we move on to the next article?
This paper really hits home for me. I mean, just last week I did a case, an 82-year-old gentleman who was ambulatory previously, wheelchair bound when he came into the hospital through the emergency department, and paralyzed right arm, floridly myelopathic. Incidentally, he tested positive for COVID, not really symptomatic, and so I had a long conversation with he and his family, and the progression of myelopathy was unacceptable for him, right? And we kept him in the hospital, waited for his COVID test to test negative, medically optimized him in every way possible. But he still, had volume overload from his cardiac issues after surgery, despite, extensive medical optimization. So ultimately, I think it becomes a question of, when do you say no, right? And that's what I don't know the answer to. I'm curious what other people think.
This is a great point that you guys raise. So if I understood Jacob's take-home points correctly, he said age is an optimization opportunity. So is there some form of a turn-back dial that we can optimize age with? I guess your smile says no. Let me ask the following question.
Well, yes, I think there's a difference between a 70-year-old, like when you're 70, whenever, you're going to probably look like you're 40, right? And act like you're 40, right? Physiologically, you won't be chronologically 70, right? I think that's a big decision maker, I'm sure, right? When you look at somebody's performance status.
No question. Yeah, my father-in-law, I always quote him. He's now 94, and I did a pretty big spine surgery on him a couple of years ago, and he 3 weeks later went to Africa to his hospital that he has and continued construction there. So chronologic age is a surrogate for I don't know what, but biologic age, neurophysiologic age is much more important. Let me ask you a factual question, Jacob. So surgical time was a adverse variable. What I struggled with in this paper was, and what NISQIP, to my assessment, when we tried to use this, didn't delineate was differentiation of anterior versus posterior surgery. Did you gain any further granular insight in that? And is this surgical duration a magnitude of surgery, invasiveness indicator? Or is this something that, for instance, through retractor time and anterior surgeries can cause predictable problems? Thank you.
So I think that's one of the limitations of this paper, is that the fact that it is a NISQIP-based paper, and there aren't really the delineations that you could get from a deep dive into patient charts or anything. So I wasn't able to delineate what that operative time, what it came from, if that was 180 minutes of retraction, or if it was if that 180 minutes included flipping the patient or proning the patient or anything like that. So there are some limitations to this, but.
Jens and everybody else, and I think Steve alluded to it, the bottom line is that we can try to optimize the patients as much as possible. And it reminds me of a 7-year-old that I did a fusion on 2 weeks ago. And he says, oh, I'm healthy as a horse and I have a heart of a 15-year-old. So we operate on him. He goes into arrhythmia and ends up getting a pacemaker. I said, well, so much for your heart of a 15-year-old. And, the thing is, you never know. And you just have to lay it out to the patient. In other words, they might feel like they're 40 or 50, but they're still 70 years old chronologically, and they still can get complications and may.
Yeah, absolutely. I really think it depends what your goals are and what the patient's goals are, and whether or not you can achieve the goals, and whether or not the procedure is this big or mega big, right? And the complication profile. So I think you have to take 2 steps back, think about what your goals are, think about what the patient's goals are, think about their comorbid risk factors, their frailty index, and then make a judgment call at the end of the day, right?
Hey, you just have to discuss with the patient, be honest, and lay it out.
I think, we have different thresholds. Obviously, you wouldn't take excessive risks on someone who just had 10 years of axial pain. But the other end of that spectrum is patient Dan is describing. It really hurts us to ignore progressive myelopathy from neurocompression, because that's all our training is based on helping that, fixing that. But it still comes down to the quality decision. Is it, are you risking a patient's life for something that's functionally disabling but is not going to kill them right off the bat? And sometimes we're pushed by the patient and their family saying, we can't live like this. But you have to remember that patients with 20 years of axial pain also tell you the same thing. I can't live this way, but they certainly can live this way. And that's the dilemma. That's what makes it hard. There's never any black and white answer for that. It's just based on your judgment and how much complications you can tolerate. And that varies from doctor to doctor and specialty to specialty. But it's an unanswerable question.
Absolutely. Maybe we can move on to the next article, guys. I think one of the most devastating problems that is very disheartening that we all probably see is a patient that has a flawless operation, their first day in the hospital, they're doing reasonably well, and then you go to examine them the second day and they can't move their biceps muscle, right? And they develop a palsy, and we all scratch our heads. How can we prevent that? So I thought, and then Dan Cavanaugh's patient that he described developed a C6 palsy, right? So we thought we would review a paper looking at C5 nerve palsy. So I think are you up for this paper?
Yeah, like you said, Dr. Ludwig, most commonly it's a C5 nerve root palsy that we see. We do see other upper cervical, but for the paper that we have selected. It's a meta-analysis looking at CV5 nerve root palsies over the last decade. As a brief background, probably one of the most common complications that we see after both anterior and posterior cervical procedures. There's been quite a bit of literature surrounding this topic over the past 25 years, with most of the work showing that posteriorly based procedures have a higher rate compared to anterior based procedures. Some of the literature citing that it's up to 10 to 30% posteriorly and as low as 1.6% anteriorly based procedures. Usually these are unilateral clinical disorders that present with paresis or weakness of the deltoid or biceps, or a combination, without any deterioration of myelopathic symptoms in these patients postoperatively. The article that we will discuss is from 2017 in Medicine. It looked at 61 total studies, looking at 721 patients that had both combination of anterior and posterior surgeries. Their overall incidence was 6.3% that they found in the meta-analysis. They did do a test for the risk of publication bias and found that the overall funnel plot was asymmetric, meaning there was no overall bias that they could glean in. Obviously, with the meta-analysis, it becomes the quality of the literature that's going in is going to dictate the quality of the results. But they did find that the cumulative anterior risk is 5% versus the cumulative posterior risk 6.2%. The interesting thing about this meta-analysis is that they were able to find some granularity in looking at specific anterior procedures. ACDFs had a higher rate of C5 nerve root palsies, 7.5% versus corpectomy and fusion anteriorly, 5.5%. And laminoplasties had a 6% risk, while laminectomy and fusions had a 12.2% overall risk. The patients that had OPLL also had a higher risk. Posteriorly based procedures, they found up to 13.1% risk, while the overall risk for the C5 nerve root palsy being 8.1% with OPLL, all comers anterior and posterior surgery. Cervical spondylotic myelopathic patients, if they have that concomitantly, they do have up to a 5% chance of having a C5 nerve root injury. And the authors also found there was a little bit of gender bias, with 5.9% of males compared to 4.1% of females having a C5 nerve root palsy postoperatively. The theoretical considerations for causes, it can be the fixed deformity that can cause less of a drift back versus if you have more drift back, potentially you have more stretch on the upper cervical nerve roots. And the other proposed mechanisms can be obviously the inadvertent nerve root injury during surgery iatrogenically, as well as spinal cord ischemia causing the decreased blood supply to that area, or this segmental spinal cord disorder and reperfusion to that area, which may be a reason why anterior cervical discectomies and fusions have a higher rate compared to corpectomy and fusion. Interesting article. I think it's one of the more recent meta-analysis, and interesting to see if they can comment more on the granularity, which they did.
Yeah, thanks. So I think this is a problem for patients with severe myelopathy, and the concerning thing for me, from my perspective, is that we don't necessarily know how to prevent it, right? Some people say do a foraminotomy, some people say don't. Some people say it's due to the width of the laminectomy and the excursion and the posterior migration of the cord. You know, I don't have my head around exactly what the issue is or what the problem is, and more importantly, how to avoid it. You know, currently we are doing, at least I will do foraminotomies to make sure that the root doesn't get kinked. I'm a believer in a foraminotomy. I don't like to tape down the shoulders. That puts undue tension on the brachial plexus, as you guys know, that worked with me. And postoperatively, we like to elevate the arms to reduce some of the tension on the brachial plexus. Anecdotally, we don't have any hard data on this. We believe that that may potentially reduce some of those issues. People also have said in the past that the risk of developing a palsy has been similar in anterior-based procedures versus posterior-based procedures. I'd love to hear from the other panelists. I've never seen, other than in trauma, I've never seen for a degenerative condition in myelopathy or radiculopathy, an anterior C5 palsy. I don't know if anybody else has had that experience. All mine have been with posterior cervical laminectomy, infusions, or laminoplasties.
Steve,
I agree, Steve. I've never seen it from the anterior cervical, but what I found fascinating, the 12% for the posterior decompression infusions, that's almost twice as much as any of the other, approaches.
That almost doesn't make sense. And obviously I echo Rick because we have the same experience. And interestingly enough, on our anteriors, we almost always tape down our shoulders. And again, like Rick said, I can't remember a C5 palsy anteriorly.
Steve, I've had two C5 palsies for degenerative conditions anteriorly, one with a corpectomy, one with an ACDF. Both of them were mild, both of them resolved by about 3 months completely. But I've definitely seen it, and it seems that they're more common for me posteriorly, which fits with this paper, but it happens.
So
Yeah,
this is,
If you have an evolving C5 palsy, do you treat steroids? Does that help? Do people know? What do they do if they see an evolving C5 palsy?
Yeah, Jens, what were your thoughts? You were about to comment.
No, thank you. So the key question is obviously, why does it happen? And again, there are a number of theories around there. For us, the best logical explanation still is traction. And again, this is going towards the anterior versus posterior argument. If we do posterior surgery, it's usually for a significant deformity reduction, like a kyphosis reduction. And obviously, if there's foraminal traction, then when the cord falls back, there's a traction phenomenon. So I think it's less a question of anterior versus posterior, but more going back to understanding why this happened and if it's a traction phenomenon. This also would include the shoulder tape down, which may be an attributive factor. So before we answer Eugene's question of what to treat, going back towards the causation and understanding that would be the most important thing.
Well, the question then becomes, right, what's the most common presentation, postoperative day 1 or 2, when you look at other studies, right? Why does it happen then as opposed to immediately after surgery? That's another question. Is it the drift back? Is it reperfusion? I still don't think we fully understand what's going on.
At last week's virtual CSRS meeting, there was one interesting paper where they said that prophylactic foraminotomy actually increased the incidence. This is the first time I'd seen that.
Yeah.
And they were saying it's maybe devascularization or drifting of the root. But it was a not reasonably good scientific study. But the first time that I saw that something we've been trained to do might be the wrong thing.
Yeah, I don't do foraminotomies because of that. I've said that. I've read that same article.
Yeah, Jack, if you think about it, right, and you think about the float back phenomenon, right, and you say, well, if I'm going to do a wide foraminotomy, I'm going to increase that float back phenomenon and increase the excursion. So it theoretically increase the risk of foraminotomy. So initially, when I first started, and I never did a foraminotomy, and then I sort of when I developed them, I said, oh my God, I would look at the CT scan and I would see a little kink, and I'd say, oh, I got to do a foraminotomy. So then I do foraminotomies, and I still get it. So it's horribly frustrating. And the problem is you could do a perfect operation and do everything right, and it still happens, right? And I just don't. It's very frustrating when you don't have a solution for a problem, as we all know.
Yeah, I agree. It's like we struggle with nerve stretch and leg pain after arthroplasty and after ALIFs also. And we tried looking for predictive factors and just couldn't find them. The variability was too much.
Absolutely. Any other thoughts before we move on? I guess to answer Eugene's question, are people with a developing C5 palsy, are people giving steroids? I do give a blast of Decadron just to do something, and I get them involved in early active range of motion. Anybody think that's a bad idea, or any other thoughts?
The only other thing you might consider would be gabapentin, although that's purely anecdotal.
Got it. All right. So moving forward, in Dan's case, Kavanaugh's case sort of alluded to this in the beginning, the most common complication we all deal with after anterior-based surgery is dysphagia, right? And luckily, most of us will counsel our patients that it resolves fairly quickly within the first couple of weeks, and rarely will it last beyond 2 to 3 months. Maybe associated with other occult problems, as in Dan's case, a recurrent laryngeal nerve problem, a superior laryngeal nerve problem, or alternatively, a devastating problem like Dan Kavanaugh's case with an esophageal perforation. So it doesn't necessarily need to be taken lightly. I think you also have to rule out a mechanical problem with your construct, especially in a large deformity, if your graft is sort of kicked forward or there's a problem with the implant. So I think Nina Lara, one of our fellows, is going to be talking about the local application. We chose an article looking at the local application of steroids. So Nina, can you sort of begin the discussion on that?
Nina, I think you may be muted.
I think you're on mute, Nina. Hey, Nina, I think you're on mute. Oh.
Just talk.
Maybe what we could do, if Nina has a technical
Hi
problem.
guys, can you hear me okay?
Yep, now we can, Nina. Sorry about that.
We're gonna switch screens. I'm here with Pete, so we're gonna,
Okay.
all right. Okay. Yeah, thanks so much. I'm gonna talk briefly about dysphagia, postoperative dysphagia. I'm gonna try to switch screens here. I know. Okay, so the article that I covered was the effect of topical steroids on swallowing following ACDF, results of a prospective double-blind randomized controlled trial. This is out of HSF by Hanjo Kim et al. So it actually hasn't been published yet, but it is accepted into Spine and accepted for publication this year. The study design, again, is a randomized double-blinded controlled trial, level 1 evidence, and the purpose was to investigate the effectiveness of local intraoperative corticosteroids at decreasing the severity of swallowing difficulty following multi-level ACDF. So a little bit of background here. So keep moving. There we go. So like Dr. Ludwig alluded to, dysphagia is the most common complication after an ACDF. Most of the time symptoms are mild, but they can be severe and they can cause significant morbidity. And oftentimes the symptoms are transient. Incidence has been reported in the literature anywhere from 1% to 79%, and that's dependent on when and how the diagnosis is made. Some common risk factors that have been identified to correlate with dysphagia are advanced age, female gender, prior history of dysfunction, longer operative time, multi-level surgeries, and hardware prominence. Swallowing studies are often abnormal in patients who are also asymptomatic. And then the literature has also shown that the site of the approach is not important. So some techniques that have been described in the literature to decrease swelling, postoperative swelling and dysphagia have been preoperative tracheal and esophageal traction exercises, decreased endotracheal tube cuff pressure, dynamic rather than static retraction, zero profile plates, and then as this article speaks about, systemic or also local corticosteroid administration. So the methods of this article, they included patients who were over the age of 18, who were undergoing multi-level ACDF for radiculopathy or myelopathy or myeloradiculopathy, and who were randomized to receive local corticosteroids in the retropharyngeal space or a placebo right after the procedure. So what they used, so all patients received 8 to 10 milliliters of IV dexamethasone prior to the case. The treatment arm was the steroid arm, and they received 40 milligrams of methylprednisolone, which was mixed with an absorbable gelatin thrombin matrix and placed in the retropharyngeal space. And then the control group just had the gelatin thrombin matrix placed in the retropharyngeal space. So that was the placebo or the control group. And they assessed different outcome measures or outcome questionnaires. They used the EAT-10 as well as the swallowing quality of life questionnaire. And they also looked at secondary measures. They looked at complications, NDI, VAS, and they assessed each outcome at post-op day 1, day 2, and then 1 month post-operatively. So the results, they had 109 patients that were included, 56 in the steroid group and 53 patients in the control arm. What they found was looking at the EAT-10 questionnaire that there was no difference post-operative day 1, or no significant difference post-operative day 1 between swallowing measures. However, post-operative day 2, the steroid group was significantly lower, and this was also true at the 1 month follow-up, that the steroid group had improved swallowing results compared to the control group. Looking at the, not shown here, looking at the swallowing quality of life questionnaire, the steroid group also had better scores than the control group at all time points. But what's interesting about this questionnaire is that the steroid group also was reported that they were less worried about choking or swallowing foods or liquids than the control group throughout the time period, the 1 month time period. And looking at secondary differences or secondary outcomes, there were no differences at 1 month in NDI or VAS scores. And then there was no significant differences in complications between the two groups at 1 month time point. So first, not mentioned here, but some limitations of this study. You know, overall, both cohorts did well. There were no significant complications with either group. However, it's a single study. There was multiple surgeons that were involved, so multiple techniques. And there were some minor differences between cohorts. The steroid group had a higher BMI, 18 minutes, shorter operative times, decreased drain use, and then slightly lower VAS, preoperative VAS scores. But overall, the cohorts were quite comparable. So their take-home points was that local administrative corticosteroids after multi-level ACDF can decrease postoperative severity and symptomatology. However, we need further literature to really identify potential complications, a longer study periods to identify if there are complications associated with topical steroid use.
Yeah, thanks, Nina. I think, you know, a very interesting article where I think the results definitely support the conclusions. It's a level 1 study. I'm glad you chose this article. I think I'm sure that there's been buzz over the past few years of using, you know, a local application of steroids and looking at it versus, you know, Decadron. Practically, I actually do both because the anesthesiologists have been giving IV steroids for nauseousness. And I also do, as you guys know, a local application. This is a data point that obviously supports that metric. You know, lessening retraction, right? Getting through the procedure in a fairly predictable fashion, not wasting steps, you know, I think are important because retraction time is important. Revision work, you know, you're more likely to develop these problems. Any other thoughts from the panelists with regards to this article, the data points, or any other thoughts on how to avoid, you know, prolonged dysphagia in their patients?
Let me shoot out from the audience, from the chat room. So Nina and team University of Maryland, thanks for picking up this most important and overlooked subject. So 2 questions from Mauricio, one from Panagiotis, the other one. Were there any more infections in the steroid group? And what happens when you put a drain into the retropharynx and you have a little, whatever, gel foam sponge with steroids in there? What happens to those steroids? Did they address that? Thanks.
No, there were no differences there were no increased risks or increased infections, whether superficial or deep, in either cohort. And no, the outcome of drain use was not described either. But I mean, typically when we place a drain, it's mostly superficial. I'm guessing when they place the gel foam, that it's pretty deep. It's probably pretty close to the plate. So I don't think that placing a drain would have any impact on the topical steroid placement.
Let me ask you another question, and that is, for me, retractor time, retractor type, and anatomic height, meaning upper levels of cervical versus lower cervical spine, are significant factors. Also, revision surgery, yes or no? So how did those variables get addressed in the study?
Yeah, so they didn't mention anything about a plate or any of those variables in this study whatsoever.
So let me ask the panel, and obviously Dr. Ludwig, many years ago, I used to love these table-mounted retractors. My previous institution did not have a lot of help. And for instance, there was this absolutely beautiful SIN frame that I got from Europe with beautiful modified Holman retractors. And I could just operate beautifully in the front of the neck without any worry about assistance strength. Nowadays, I don't use it at all anymore because I'm really worried that by protracted retraction, even if I stay under half an hour per level, I just create too much of a pressure problem or tension problem. So table-mounted retractors, yes, no, or selective handheld retraction. And what do I do in the upper cervical spine if I have to resect a C2 tumor, for instance?
Yeah, Jens, I think you so astutely pointed out what I call the dysphagia maker, right? The table-mounted retractor. I do believe that there is a treatment effect of that table-mounted retractor versus handheld, and we use a shadow line. I mean, I think it's irrelevant with the brand, right? But we do, for multi-level procedures, we use a non-table-mounted retractor. At least that's my preference. Between each level, I take down the retractor, I let things revascularize, irrigate, put the retractor back in. I think it is tough getting, C2. I think meticulous dissection of the soft tissues and creating a little bit longer for that tumor you described in a high cervical zone allows you, the planes are a little bit more supple, but allows you to get more proximal exposure. I don't know, Kavanaugh or Eugene or Gil, any other thoughts on that?
Yeah, I mean,
with a soft tissue dissection, early on when I didn't do much soft tissue dissection with a subplatysmal kind of undermining that, I got a lot of higher dysphagia rate, but I spent an extra 5 minutes making sure all the soft tissues are released, that the retractors don't have a lot of force on them. One thing that I've noticed anecdotally, and I don't know if anyone's done this, is sometimes with the shadow line retractors, you can hang a 1 pound weight or a 2 pound weight on the medial side so you don't get as much. But I've noticed that I've gotten a little bit more dysphagia when I hang weights on that. That's just anecdotal. I've never had it randomized. So I don't typically do weights, and I don't do table-mounted retractors.
Can I ask a couple questions, Steve?
Absolutely.
About the study. So you brought up the point about the anesthesiologist giving Decadron for nausea. Was that looked at in this paper? Because that could be a confounding factor. Topical steroids, do they all get systemic as well, or none of them? That's question number one. And then question number two is the whole definition of dysphagia. It's so subjective, because you got these tough patients and say, how are you doing post-op? I'm fine. And they probably have a little sore throat or a day or two of that. And then you've got the kind of the symptom magnifiers that it's a big deal. How is that taken care of in the study as well?
Yeah, Scott, those are great questions. Nina, can you comment on the use of dexamethasone on the HSS and comment on the disease-specific outcomes measures? I believe they used the EAT measure, but can you comment on the disease-specific outcome measures for Dr. Blumenthal?
Yeah, so can you put on mute? So they did not, they gave everyone 8 to 10 milliliters of IV dexamethasone. So both the control and the steroid group had IV dexamethasone, so they did not differentiate, and there were no differences, statistical differences between cohorts with IV use. Yeah, I mean, the EAT 10 as well as the swallowing quality of life have different they're all subjective questionnaires and outcome measures that have been validated for swallowing or for dysphagia. But it's all, it's all patient perspective and how if they have fear of swallowing, if they feel like they can swallow certain liquids and certain foods, but both assess kind of pain and fear of swallowing.
Scott, when do you counsel ENT or consult ENT? At what point in the postoperative course, when patients are complaining to you anecdotally about dysphagia, after an ACDF procedure, when do you pull the trigger and send them to ENT for an evaluation?
Shooting from the hip, probably 6 weeks. If they're still complaining of it at their 6-week visit, at 2 weeks, it's kind of like, okay, you can still sometimes see some soft tissue swelling on their post-op film, but by 6 weeks, I would think that it should have resolved.
Yep.
Hey, Steve, one thing that I've noticed, and this goes back to what Jens said, in the upper cervical spine, at least anecdotally, I found there's a higher incidence. And part of it is because I think we stretch the superior laryngeal nerve, at least this is what the ENT folks tell me. So if I'm doing a C3-4, if I do it, I end up stretching it, and I tell all the patients who have trouble swallowing. So what I've reverted to is having one of our ENT surgeons do the dissection, and I watch how they do it. They do it much differently than what we do. Ours was, you put the finger in, you stretch things, and, somebody else said they do a little more dissection. But they do it sharply. And since I've used the ENT for the higher cervical spine, I've not seen the dysphagia problem. Now, it's an N of, 20, 30, but it's not a study. So just a point. But I rarely see it at C5, 6, and C6, 7.
Yeah, that's a really great point, Rich. I think, so just for clarity's sake, so primary C3-4 and above, your algorithm, consult ENT, assistance for exposure with the optimal outcome to avoid the dysphagia, with that sole purpose.
Yes, correct.
And I'll echo that also, Stephen. It's interesting to watch their approach. They come in a little more anterolaterally, and they do sharp dissection all the way down to the spine, which we teach not to do. And there's very minimal retraction of the hypopharynx that way, whereas ours is really an extension of our lower cervical training, to get under the esophagus and kind of bring everything up and over. And there's a dramatic decrease in dysphagia in those high cervical levels since Rick and I have started using ENT for the C3-4 exposure. So a little bit of a pain in scheduling, but it's not the worst thing in the world.
Excellent.
Let me get back to the balloon. So I think there was a conflict between Utah where they had said the balloon matters, so let's deflate the balloon during retractor time, and Philly where they then said, oh, it doesn't matter. I think there was a CSRS study that debunked that, but I still actually deflated because when we did our anatomy studies, we did see a big difference of retropharyngeal pressure exacerbated by excessive retraction. So Steve and team, what do you think about that? Should we deflate temporarily whilst we retract or not?
I personally am a big believer in deflating the tube. I believe that there is an effect of that. And I have read some of those studies. The interesting thing about those pressure studies that Jens sort of brought up, and I'd love to hear Rich and Jack and Scott's thoughts on this, and Jens, about disc replacement versus ACDF, right? And there is some work that is suggestive because of you do less retraction with disc arthroplasty, there's less dysphagia. Any thoughts on that, guys?
Steve, actually, I was going to ask the question, how most people place the retractors. I use the smooth tooth retractors, but I make sure that I do a subperiosteal dissection of the longest coli so I can see out to the smile or to the uncus. So I don't think I do any less retraction, and I don't know if it makes any difference on the esophagus, but at least the retractor blades are pulling on the muscle. And sometimes it's hard, they'll slip out. But I don't use the smooth blades that are retracting directly on the esophagus. So no difference between the two. In
the disc in the original IDE studies on disc replacement, there was a lesser incidence of dysphagia, and we kind of wrote that off to the fact that the original studies you had to use a plate. You couldn't use the zero profile devices. I don't know whether that's true or not, but that's kind of what we thought.
Great. Yeah, and I do the longest dissection as well. I think that Rich was describing. I like to see the uncus as well. That's just essentially my workflow and the way I was taught as well. Probably the most highest incidence problem that we see with posterior related approaches, just shifting gears to the back, are with wound healing issues, dehiscence, and wound related infections. So we thought it would be appropriate to look at the effects of local vancomycin and on the prevention of postoperative wound infection. So I think, Pete, you have this meta-analysis that you chose.
Yeah, thanks. So if I can get the screen, perfect. So this is a meta-analysis. I chose this, in all honesty, it's a meta-analysis of vancomycin used throughout the spine and posterior approaches, but it was the most recent meta-analysis, and I think the data is still helpful in discussing posterior cervical approaches. But this was from 2019. It was a meta-analysis of multiple databases through September of 2018. And they reviewed, thousands, hundreds of studies, but in the end, 21 studies were included that involved 15,000 patients. For their inclusion criteria, they were looking for any study in which there was a study group with vancomycin compared with a control group, and any study that had vancomycin used before closure. And they wanted to look at qualitative bacterial cultures as their endpoint results. If there was no control group, pediatric studies, any studies missing data, or any studies including patients with preoperative infections, those were excluded. So this is just a list of the studies. We're not going to read through all these, but just to point out that most of these were, in the end, retrospective cohort studies. There were 2 randomized controlled trials that were included in the meta-analysis, but always know where your data is coming from. So they divided their results looking at the types of infections that occurred with using the vancomycin powder versus the control group. So looking at their gram-positive infections, they did find a significant effect of the vancomycin powder in reduced odds ratio compared to the control groups for these patients. And you may expect that. I mean, vancomycin does have better coverage for gram-positive infections. If you look at, these were the actual numbers for the types of infections. And as you would probably predict, Staph aureus at the top of that list. When they looked at gram-negative infections, and this was probably what they were most interested in looking at the study was, you wouldn't expect vancomycin to necessarily decrease the rate of gram-negative infections because it doesn't have coverage there, but there is some concern that by eliminating a lot of the gram-positive bacteria in the wound, that you'd have a higher incidence potentially of gram-negative infections. And what they showed was that there really was no significant difference or correlation with using the vancomycin powder and no vancomycin powder in their data to suggest that it affected the amount of gram-negative infections either way. And then again, these are just the numbers of the gram-negative infections that they had or that they saw. In terms of mixed floor infections, again, the vancomycin powder did have actually had a significant effect based on their data and an improved odds ratio of a decreased infection rate. And somewhat, expectedly for methicillin-resistant drugs, so mostly MRSA or coag-negative staph, they also found a significant effect where most of the studies tended towards decreased infection rates with the vancomycin powder. So, this is a meta-analysis. You're always limited by the data that are included in the study. All these different studies had different skin preps, different study populations, different areas of the spine that were operated on. So you have to consider that when looking at these large numbers. But, I think the goal of the study is to have, for an outcome such as infection where the hit rate on getting infections is relatively low, to get a study where you're able to actually use the numbers. You really need a lot of numbers. So I think this was a good attempt to get a larger number to compare. And I mean, even despite that, with 15,000 patients included in the study, I think the study is still probably underpowered to make, a true decision on this. But overall, The study did show a generally positive effect of the vancomycin powder to decrease the rate of gram-positive infections, and they did not find any evidence that suggested it increased the rate of gram-negative infections, and it certainly didn't reduce the rate of gram-negative infections.
Yeah, thanks, Pete. I think, you know, the development of a postoperative infection, we have about 5 minutes, I think, for discussion, and is an absolute devastating problem, right? And anything we could do to mitigate that risk is obviously important. You know, other than chlorhexidine scrubs preoperatively, mupirocin, you know, intranasal mupirocin that we do here for 5 days, I think there is evidence to suggest that the vancomycin powder creates a local treatment effect to reduce postoperative infections. It seems as though in the cervical spine, I never applied anteriorly. And I think if you're dealing with an infection anteriorly, you absolutely need to rule out an occult esophageal injury until proven otherwise. We obviously see it more commonly posteriorly. I think the data and some of those, if you get into the granularity of the details of the meta-analysis, the posterior data is a little bit weaker. You know, just doing a little deeper dive into that meta-analysis and looking at the posterior cervical, there may not be a treatment effect as much as the thoracolumbar patients. However, I still do it just because I feel as though that risk is just something I absolutely want to avoid. We also do local betadine checks. And I think it's important that you pointed out, Pete, that even though our infectious disease doctors will go crazy, right, with our local application and vancomycin use, this data supports that, you know, the development of a superinfection isn't necessarily true, even though, you know, you suggested some of the downsides of the data analysis. So any other thoughts with infection prevention from the panelists?
So for me, thank you for bringing this up. Again, this was not specific to the cervical spine, but our biggest fear is obviously posterior cervical wound healing problems. We had a chat going on in the background. And for me, one of the biggest learning points is quality of fascial repair. So persistent wound drainage in the back is a very negative setup for a wound infection. And again, in my own clinical practice, usually I find a very insufficient fascial closure, especially in larger patients or in healing impaired patients. So I learned from our plastic surgeon who's here in the room, Dr. Gottlieb, how important it is to have the right suture material. So a slow resorbing suture with a high quality apical closure, especially caudally underneath the nuchal ligament, is so important. And when we delegate this to an intern where basically 1 or 2 quality fascial sutures are put in and then the rest is sub-Q more or less, it's bound to fail. So the variable quality of wound closure relative to posterior infections for me is an easy fix if we pay attention to detail. Sorry for the editorialization here.
I would echo that statement. I switched from a Vicryl to like a PDS or an Ethibond for my fascial closure several years ago, and I've had a much better success rate with that and wound dehiscence, wound complications, etc.
Are the panelists, I'd like to hear, is everybody using vancomycin for posterior directed procedures? Laminectomy fusion, laminoplasty? Maybe we can go around yes or no. I am. Just a minute.
No.
Rick, no?
Nope.
Jens, yes?
Yes.
Scott?
No.
No. Jack? Ziegler?
No. Yeah, not routinely.
Interesting. How about thoracolumbar?
Absolutely. Again, from everything that we see now, the lack of systemic influence on resistance development has been very favorable. And again, the more dead space you have, the more putting a topical antibiotic that works for about 24 to 48 hours makes sense.
Betadine soaks are another thing that we've been implementing, not only for, we did it with trauma patients, but 2-minute betadine soaks with a dilute solution we're doing for all posterior directed procedures as well. Another trick to, once again, mitigate. We throw everything at Maryland at our patients. We may be the infection capital. MRSA started it in Baltimore because of all the IVDA use. So unfortunately, we're the MRSA capital of the world. The world can thank us. But the But I think there is an effect of the betadine and the vancomycin, at least in our patient population.
Hey, the hour is up. University of Maryland, you did fantastically. Let's have Dr.
These were great papers, great talks.
Thank you guys for having us. We appreciate the time.
It's wonderful.
Everybody be safe. Have a happy holiday, the best you can have.
Well, I think Happy New Year. I think we'll reconvene in 2021. So good luck with everybody's vaccinations.
Yes.
Yes.
Hopefully it won't turn into anything.